Well, I'm glad you brought that up, Steve. That is the other thing here is the arc of change from MCI to Alzheimer's usually is a few years, and these trials were only about a year and a half. So maybe the late effects are going to come up, and we just need to wait a while on the people who are in Emerge and Engage. I see that Charlie's on too from the ADRC. Wonder, Charlie, if you've got some thoughts.
Yeah, I do, Wayne. This is Charlie Burnick from the Memory and Brain Wellness. So yeah, so I'm actually kind of on the opposite end of the spectrum. That is, I'm somewhat bullish about this product. I mean, admittedly, as you pointed out, the studies were, I mean, there's problems interpreting the studies, but this is it's a disease modifying therapy. So, and even in looking at those lines, I mean, if you could kind of imagine that they were separating over time. That is, the longer duration, the more separation you got, which is what you'd see with a disease modifying therapy. And as you pointed out, I mean, it is difficult to show. It's difficult to show a benefit in mild cognitive impairment because people don't change that much over 18 months, just as you said. And I think, as far as the kind of the vaccination trials earlier, it's kind of a different population because people were at that time looking at people with Alzheimer's disease, dementia, where, the whole field is saying, all right, if you're going to remove amyloid, you really have to do it early. So, which is the idea of the AHEAD study, which I'll make a pitch for the geriatricians. So, I mean, they're looking at anti-amyloid drugs in people who are clinically normal, but have evidence of amyloid in the brain, with the thought that if you remove it early enough, you can change the trajectory. So, these aren't obviously cures, but even a 20%, reduction in course, or 40% if you look at functional change over 18 months, could be significant. So, I mean, and I also say that Aducanumab, the same type of findings are also seen in other drugs. So Lilly has a product, Donanemab, which is they're doing their second trial, the confirmatory trial. There's another product from Eisai. They all are showing the same kind of degree of benefit. Well, what I would call benefit. So there's some consistency among all these monoclonal antibodies. So yeah, I mean, people obviously want something, but I think, I think there might be something there. And I think the flip side is to say, all right, do another study in 4 years in a disease where if you do nothing, I mean, you know exactly what's going to happen, is also ethically not correct. So, I mean, I understand the science about it and the criticism that this has had, but I think there's another side, and I think there's a fair amount of trialists who kind of feel the same way, that yeah, this isn't clean, it's not really clean, but there's enough signal to be somewhat more enthusiastic about it than some people are.
Thanks, Charlie.
Yeah.
And Barack, I was wondering kind of what you're hearing. You're in touch with a lot of advocacy organizations, and do you have a gut reaction to these data?
I mean, my biggest concern is the chilling effect it's going to have on ongoing research, and I think that what bothers me a little bit about the AZT analogy is that was at a time when nobody had prescription drug benefit, and so people couldn't afford AZT, and so they had a lot of incentive to continue enrolling in HIV treatment trials. Now Medicare is required by law to cover this drug because it's FDA approved, and so I have a lot of concern that it really will be a setback in finding more effective treatments than this.
Yeah, I had to smile watching Fauci on TV this week and remembering this as I was tooling up for this talk, and him facing down thousands of mad gay men in Montreal, and then facing down Trump. I mean, Trump's nothing compared to what he saw in Montreal. He was well schooled in keeping some equanimity in the face of adversity. But
and I would also say, I mean, your question about, should the FDA be influenced by political pressure? And I mean, I think if the FDA had been influenced by political pressure over the COVID vaccine issue, we all would have been sort of up in arms and in the streets.
yeah,
I mean, I think I think the FDA is there to be our scientific standard bearer, to represent the interest of the American people, to make sure that political pressure and financial pressure doesn't influence what happens with the approval of drugs in this country. And so to me, I am uncomfortable with the clear sense that political pressure rather than scientific data drove this decision, because the advisory board was 10-0, and the one person who didn't vote against approval abstained. So it's not even that there was one person on the advisory committee who voted in favor. It was really 0 people in the advisory board voted in favor. And so, I mean, I am stuck and concerned about what this is going to mean long term.
Yeah, this medicine will probably be given in memory and brain wellness, or at least under the auspices of the ADRC. Kimmy, I see you're on, and Charlie. Kimmy, you feeling okay about this? Because you guys will be given it.
Well, I think that we want to do right by our patients, and I think part of our service is to make sure that when there is a FDA approved medication, that it's used appropriately. So we are going through the process of making, and Charlie can definitely speak to this, but we're making Aducanumab available. But I think that's also a question, is who will be prescribing this? It seems as though and I'd be interested to hear from the group, is there a comfort level in prescribing this? Will this end up being a subspecialties prescription, versus we also worry that there may be infusion centers popping up, sort of rogue centers, and potentially off-label use for cash, and that we may see the fallout of that, the people with side effects, potentially devastating side effects if it's used off-label. But we don't know. But yes, it is. We are working to have it be on the formulary at Harborview.
Yeah, it's complicated to give. I fully expect in half a year that there'll be an ad for Aducanumab on 60 Minutes. People will say, ask your doctor for this medicine. And I would imagine what you just outlined, Kimmy, it is perhaps likely. We all know as clinicians, there's no sharp line between MCI and mild AD, not one between mild AD and moderate AD. What we call moderate AD is really pretty advanced. So I think indication creep could be a given. And there's lots of people who do have this much money. The son of my patient, this pocket change, 56 grand. I mean, he can eat. He had no trouble with the amount of money that might be involved here. His mom was not in a position really to decide. He's deciding for her. So that's a little worrisome to me. But maybe we got to go through this as clinicians, as society, to get to the point 25 years from now, where we have multi-agent therapy that isn't so hard to take. Time will tell.
I would just sort of circle back to what Angela said before about how many people were excluded from these trials. I mean, you could not be in these trials if you had hypertension or diabetes. You know, so it's just a really large number of the people who we're going to be seeing who could potentially ask for it.
Good point. Yeah.
The other thing I've been thinking about a lot is just the logistics of this. You know, someone has to come in every 4 weeks and get their infusion. They have to have an MRI before, they have to have an MRI at least before the 7th and the 12th infusion. That's a lot of time back and forth, and, you know, time spent in a center, time of family away from their work if someone needs a ride, and time away from other things that might be, unless you're going to do like cognitive enhancement activities during the infusion, I guess, which would be, you know, anyway,
We're actually thinking
I'm
about
just
that.
thinking about, like, there's a lot more to it than just the cost of the tests and the drug. There's this opportunity cost of other things you can be spending your time doing.
Right. Well, the ship has sailed, my dear colleagues. This is out of the barn. So it's not like we can put it back in there. This is going to move forward, right? So I think as a group, we should continue the discussion. We're almost out of time this morning, but let's keep thinking together about how to respond to our patients, how to respond if we're interviewed on the radio about it, how to respond professionally, because it's not going to come across very well to just say no, and it's not going to be very smart to always just say yes. So I'm hoping you all can help me in how to talk about this with colleagues and with others, and especially with patients and families.
So it seems to me that if a patient came to me and said, or a family member had said, what change will I see? And we talk about improvement, but this isn't improving. This is slowing decline. So what I would say to that patient is that in 18 months, you will see a noticeable further deterioration. And that if you didn't give the drug, I mean, and I'm basing this on assuming all the best data. This is true. You will have a noticeable decline that will continue by 18 months, and that the degree to which the decline is decreased would be unnoticeable. Is that true? Are both those statements true?
Yeah.
So I'm going to tell you, you're going to be going through all this stuff and you will not be able to see a change as if you weren't on the drug.
Of course, that's kind of what we told people we were putting on donepezil too early on. So, well, you know, usually we don't notice much of anything, but what we're hoping is that not as much decline will occur if you take this medicine. Would have been a pretty reasonable statement, and still is a reasonable statement to people starting donepezil. Well, great. Thanks, everybody. We're out of time. I'm sure you all have a 9 o'clock Zoom you have to get to, and I'm glad that, you know, we had this chance to talk about these studies. I would imagine, Kimmy or Charlie, do you know when these are actually going to be published? No telling. We'll see. Okay. Well, pretty soon you all will be seeing these, no doubt, in major medical journals, and we'll see how the actual read. Hopefully it's somewhat similar to what I told you this morning, but time will tell. Okay. Thanks, everybody. Appreciate you coming. Bye-bye.
Thanks.